Hello and welcome back to my channel, where we talk all things rheumatology related. Today we'll get down to the basics and talk about ferritin. Ferritin is an intracellular iron storage protein found in macrophages of the reticuloendothelial system, such as liver, spleen, and bone marrow, hepatocytes, skeletal muscle, and serum. Normal values for men are between 30 to 400 nanograms per milliliter, and for women between 15 and 150 nanograms per milliliter. One ferritin molecule can hold up to 4,500 iron ions. Ferritin is not only an iron storage protein, but is also an inflammatory marker. Inflammation from various reasons causes an increase in inflammatory cytokines such as interleukin 6 and tumor necrosis factor alpha. Inflammation can be caused by infections, malignancies, or autoimmune diseases. These inflammatory cytokines increase ferritin synthesis and also increase hepcidin production by the liver, which in turn also increases ferritin synthesis and decreases intestinal iron absorption. Why is ferritin such an important blood test? Well, for once, ferritin helps us in the differential diagnosis of iron deficiency anemia to anemia of chronic disease. Levels of less than 30 nanograms per milliliter are seen in iron deficiency anemia, while anemia in the context of chronic disease usually has normal or high levels of ferritin. Iron deficiency anemia can be caused by a chronic blood loss, such in the case of gastrointestinal cancer or in the case of poor intake or malabsorption. If there is a high suspicion of gastrointestinal cancer, a fecal occult blood test can be helpful. Higher levels of iron can be seen in iron overload states, such as hemochromatosis or secondary to repeated transfusions, or in inflammatory states. Ferritin levels greater than 2000 nanograms per milliliter are seen in hyperferritinemic syndromes, which we will talk about later in the video. As a quick recap, ferritin levels are increased by inflammation, infection, malignancies, iron overload states such as hemochromatosis and liver injury, and decreased by iron, protein, and zinc deficiency. Iron is an essential element for nearly all bacteria to thrive. So in infections, ferritin, which is the deposit form of iron, increases, macrophages sequestrate iron and do not release it in the circulation, and as a result, serum iron decreases. This represents an innate protection mechanism against infections. Conversely, in states of iron overload, there is an increased susceptibility to bacterial infections, particularly those caused by Vibrio vulnificus and Yersinia enterocolitica. Following the same reasoning, in chronic inflammatory conditions, many pathogens are restricted by the resulting iron deficiency. Ferritin can be either glycosylated or non-glycosylated. In healthy people, 50 to 80% is glycosylated. This measurement can help in hyperferritinemic syndromes, but is not routinely available. Next, we'll talk about the hyperferritinemic syndromes, starting with adult onset Still's disease, a condition that lies at the crossroads between autoinflammation and autoimmunity. In this disease, ferritin levels are typically above 1000 nanograms per milliliter, and the glycosylated fraction usually represents less than 20% of total ferritin. The proportion of glycosylated ferritin is also included as one of the classification criteria proposed by Fotrel. Ferritin levels tend to correlate with disease activity, so monitoring them during follow-up can be very useful. Adult onset Still's disease presents with daily high fevers, salmon peak evanescent rash, sore throat, arthritis, lymphadenopathy and splenomegaly, liver dysfunction with negative rheumatoid factor and antinuclear antibodies. The second hyperferritinemic syndrome is called macrophage activation syndrome and is a life-threatening condition caused by an uncontrolled cytokine storm resulting in hemophagocytosis with cytopenias, multi-organ dysfunction, and potentially death. Macrophage activation syndrome can be triggered by several conditions. Autoimmune diseases are the most frequent causes, particularly adult onset Still's disease, systemic juvenile idiopathic arthritis, and lupus. Other triggers include malignancies, such as lymphomas, infections, mainly viral, and certain medications. Notably, SARS-CoV-2 infection has also been reported to precipitate MAS. In 2016, Pediatric Rheumatology International Trial Organization, or PRINTO, published classification criteria for systemic juvenile idiopathic arthritis that help distinguish macrophage activation syndrome from active systemic juvenile arthritis without macrophage activation syndrome. These criteria include fever plus ferritin more than 684 nanograms per milliliter, associated with two other criteria: low platelets, high aspartate aminotransferase, low fibrinogen, and high triglycerides. There are other conditions associated with hyperferritinemia that we should not forget about: severe infections or sepsis, catastrophic antiphospholipid syndrome, and severe SARS-CoV-2 infections. Ferritin can also be elevated in liver disease. And for those who stayed until the very end, the new ERS-EULAR guidelines for interstitial lung disease highlight that patients with immune-mediated myositis and elevated ferritin have a worse prognosis with faster disease progression and a higher risk of mortality. If you enjoyed this video, please give it a like and a follow, and don't forget to check out my other videos.